Hi, good morning, Dr. Naveen.
Hi, good morning to you.
Hi.
Thank you really for getting me to your team.
It's our pleasure. It's a pleasure to be with you. We're still having 15 minutes, but I think the delegates starting the login to the application.
You are at workplace today.
Yeah, the total registered delegate is exceeding the 500.
Oh, okay.
Yeah. So we're expecting a good number to attend this webinar today.
I think Friday is a holiday and Sunday is working day for you.
Yeah, so the first working day. And because of this month is Ramadan, so this is why we changed the time to be in the morning.
That's right.
So you have temperature 37.9
Yeah, we give her the paracetamol
after the antibiotic. Okay. Injection paracetamol.
Yeah.
Good morning, all.
Hi, good morning, Dr. Vanitha.
I'm
Good
sorry
morning,
to
ma'am.
say good morning, Dr. Naveen.
Thank you for all the efforts you have been taking.
Thank you for agreeing to come over to give us. There's a lot of people who are looking forward for your talk. You were listed, and a lot of people were like, okay, Dr. Naveen Jain is coming today. So some people thought you're coming to us. That would be good as well. Actually, sorry for the last minute hitches that we happen to encounter. This is because NEHRA has some particular requirements,
I
and
understand.
we don't sift through the documents they ask, and we send, and we managed it at the last minute. It's just before talking to you, it got approved. And a lot
Lovely.
of attendees come in for the CME points. They need it for their license requirements also.
Both the systems
Okay.
seem to be very nice and progressive. That uh, there is a concept called license. I know in India we surely have degrees, but we don't have that word by name license.
Yeah.
And even the levels of practice are not regulated. And similarly, like you said, CME points are becoming important, but still not to the extent that they're critical. So,
Yeah. Not mandatory as such. Yeah.
mm,
No, as such, it has double-edged sword. We can say that it is becoming mandatory. It is not conceptually reflected in people getting it as an education, as a requirement. They just figuratively acquire the points, not really serving the purpose. But maybe somewhere down the lane that will also become proper. But from our purpose, we are serving the needs of keeping the practice community abreast with what's happening as well. So it's serving both purposes. Dr. Ranjan, I think, would probably be there, and he's been championing the cause of getting us the good expertise from IAP background to deliver these good lectures for us. And then we are complementing it with suitably similar topics and discussion from our end with some similar expertise. And it so far has been received well, and then it's going good. Dr. Jamila would be there, and Dr. Jamila, probably both of you identify each other in good
she
stead.
has been a lovely colleague of ours for 3 years
Yeah.
and has done wonderful research work when she was here.
Yeah, we gathered as much when the eyes lit up when we said it's Dr. Naveen Jain. So the admiration is mutual. So you will meet her today. And I think she might be around. I'll just check.
I think Dr. Mona is already joined also.
Okay. Good morning, Dr. Muna. I'll just check it.
How are you?
Good morning.
I'm trying.
Hi,
Thank you
hi.
for agreeing to come over today, doctor.
How are you?
We are fine, doctor. Thank you.
I'm trying to open. Okay, opened.
Good morning,
صباح الخير
doctor.
دكتور محمد شلونك؟
Yeah, صباح الخير دكتورة. Good morning. Hi.
Let me introduce you both to each other, speakers. Dr. Muna, Dr. Naveen is also around. Dr. Naveen is speaker from IAP.
Okay,
You both
nice to
are.
meet you. Nice to work with you.
Good morning, ma'am.
Good morning. I was thinking today is for us, you know, the last 10 days of Ramadan. It is very difficult to join, to have a meeting, but Dr. Muhammad, he was insisting to have it. He said he won't.
Yeah, we try to keep it.
routine.
We try to keep it. It is a monthly webinar, so we don't want to miss 1 month, even it is Ramadan.
Exactly.
But,
it is going
yeah,
really good. And we didn't want to interrupt it for any reasons. It's at whatever conducive time, we will flex it according to both the speakers' requirements, and then we'll go ahead.
I know that.
Thank you very much, Dr. Muna, for complying with our request. Yeah.
Hi, Dr. Ranjan.
Hi, good morning.
Yeah,
How are
it
you
is
all?
Yeah,
morning,
hi.
doctor.
Nice to see you
You
again,
know
Dr.
those
Good
Ranjan.
Ramadan
afternoon.
timelines. Dr.
I
Ranjan, good morning.
good morning. I really admire your tenacity. I just heard, yes, it is month of Ramadan. It's not easy to, uh, you know, hold a meeting and muster the, you know, listeners. Well done.
Yeah,
Good morning, sir.
the
Ranjan sir, good morning.
Good morning, Naveen.
Thank you. Thank you for inviting me to this group.
Well, it is all the Bahrain people who are organizing it. Their thirst for knowledge and discussion is really amazing.
It's our pleasure, doctors, all three of you. It's very kind of you to comply with our needs and coming over on this day, Ramadan for Dr. Munna, Sunday for Dr. Ranjan and Dr. Naveen. Thank you all. In a moment, we'll be getting started. So I'll just see if
No,
Dr.
Dr. Muhammad Salman and Dr. Vanita are the what shall I say, the railway track of this program.
Yeah, it's our pleasure. I think it's a good that we are start this experience sharing knowledge between Bahrain and India. I think maybe this is the first time such collaboration between two countries, and to continue for like almost now
It's
6
it's the
months.
7th edition.
Fifth edition, sir. Fifth.
Fifth, is it?
Webinar is fifth,
Yeah.
physical one.
Yeah, but we did
So
have
it's one,
one
with one
October.
See,
symposium, so it's almost
another
6
thing which we have to admire is the secretary of IAP, in spite of his busy schedule,
I am always
attends
here.
this. Attends this. I mean, it's really admirable. And
Yeah.
Naveen Jain, a authority on
Neonatology.
childhood development, yeah, agreed, readily when I requested him. Thanks, Naveen.
And our guiding force is Dr. Ranjan Pejawar, always here to lies and everything.
Thank you. Thank you.
For sure. It's
If you have
Yeah.
if you have people like Vanita and Muhammad Salman, it's very easy.
Yeah.
welcome, Dr. Yogesh.
Yeah,
Hi,
Dr.
Dr. Yogesh. How are you?
Yeah, Dr. Muhammad. I'm good. Today
I
I'm
missed one or two. I missed one or two because Sundays usually there'll be some family or social uh, occasions, but today the timing is suitable.
yeah. Today timing suitable and people ask this is a good time because what is happening sometimes the time zone difference. People ask the 10:30 am. I told no, it is 1 p.m. Even some senior people want to join.
Yeah. They'll do their rounds. Actually, somebody called me, Dr. Walvekar called me from Mumbai yesterday to say that he's joining, and I hope to
Yeah.
see you. Yeah.
Yeah.
Yogesh sir, Vasant sir is busy in another meeting. He told you to take the chair, sir.
Okay, sir, no issue. Even Dr. Neelam Mohan madam join, then let me know, or Dr. Basavaraj sir join then. Huh?
Basura sir is also in a meeting. He may join in between, but
Okay.
Neelam madam will join, sir.
Neelam madam is then she will take.
She,
Huh?
she said she will be joining. I'll just check.
Okay. Ask her madam to join, huh?
Yeah.
Because I am joining through the mobile, so that I may face the difficulty.
Okay.
We will get started in a moment. I'm waiting for one of our co-moderators, Dr. Jamila. She'll be here in a moment.
No issue, madam. We will take under 4-5 minutes. No issue. Let everyone join.
Yeah.
Because in India also the same. Here the lunch time.
Yeah, I think the speakers are pressed for time also. I'm conscious of that. I'll just wait for another minute or two and we will get started. I think we will introduce each other in the meanwhile, whilst the topic and the CME gets.
Neelam madam will be joining in a minute.
Okay.
We're having 127 delegate now.
Good number, good number.
This one you can let report, doctor, that blood is ready. Do have. And one more patient. Send to what?
Sorry, I am in the clinic, so sorry for disturbance. I will mute myself.
What just happened? Something else, whiteboard is coming up. Mr. Saji?
So it is maybe one of the speaker will
Yeah,
try
ma'am.
to.
Just start. Madam is facing some difficulty to join, but she'll be joining.
No,
Yeah, I
some
think we
whiteboard has come up.
First share.
Somebody is doing something.
Yeah.
You can delete that.
Hello.
Hello, Dr. Neelam.
Yeah. So Saji, you take a control, Saji, and stop the sharing.
Yes, sir. Yes, sir.
Someone is doing following Gudditi Bhubaneswar. Yeah, someone is there.
Yes, sir. Yes, sir. I'm just telling to stop the sharing.
Yeah.
Yeah, ma'am, you can.
Yeah, thank you. I think you'll get the recording for us.
Yes.
Filtering all the stuff that are getting out of control. I'm not gonna be the host, right? Saji can take charge of this.
Yeah, I'm there. Whom else you want me to make the host?
Because both me, maybe Dr. Jamila, I'm not seeing her signed in. I'll just check. Yeah, she's in.
Jamila. Okay.
Dr. Jamila James, yeah.
Jelena James.
Dr. Jamila James,
Okay.
she's there. The list.
Jilna. Okay. Yeah, I've made her co-host. Yeah, ma'am, you can start.
No, it is Jamila James. I didn't know who you. Jemi.
Okay, ठीक है.
Okay. Okay, good morning. Welcome all to this webinar session. Although we have labeled it 5, we've had 7 sessions. We had one live session over here in Bahrain. Including that, we are on the 7th session since we began. For those few who are joining for the first time, a brief intro of what we are. We are a collaboration from American Mission Hospital with Indian Academy of Pediatrics. And we gotten started with a memorandum of understanding that we will do a monthly seminars with expertise from IAP and an interactive expertise from some source in Bahrain. And this will be a 1-hour seminar with both experts delivering a 30-minute session and followed by an interactive session with the audience. And we have so far covered several subspecialties ranging from endocrinology, nephrology, and such. And here we are with the current session of neonatology and developmental pediatrics. We are glad to be hosting 2 eminent neonatologists from their parts of the world of practice. Dr. Naveen, Jain, and Dr. Mona. And we have Dr. Jamila James, who is a consultant neonatologist with King Hamad American Mission Hospital, to moderate the session. The theme of today's webinar is early infant development. Both the neonatologists will be delivering some topics which we will introduce in the coming times. We have the IAP presidents and IAP liaison, international liaison, Dr. Ranjan Pejawar with us, who will start the webinar with a few words of encouragement before we get started with the actual CME. I would like to invite Dr. Yogesh, who is the Secretary of IAP current pediatric sessions, and Dr. Neelam, who would be the elect president, who she is available to open the Dr. Neelam or Dr. Yogesh, could we have you over the floor to deliver your words of initiation, or Dr. Ranjan?
Shaji, please check Dr. Neelam Mohan, Madam Judge. Yes,
Yeah,
Madam is
I'm
here.
here.
Yeah. Okay.
So I was always there.
So please
Okay.
go ahead, Madam. Yeah, because Dr.
Thank
Vasant
you
is
so much.
busy. Yeah.
Thank you so much. I'm pleased to introduce myself as Dr. Neelam Mohan, President-elect IAP, and this is a beautiful endeavor of IAP with Bahrain, where today's topic seemed very interesting. For those who don't know me, I'm a director in Department of Pediatric Gastroenterology, Hepatology, and Transplant. But I was saying yesterday, if I wouldn't have been a gastroenterologist, I would have been a neonatologist. And India is home to 3.5 million preterms, birth annually. And I think that makes us globally one of the highest number of preterms that are born in India. So globally, we are among the top. And with that, I think these small lives, they teach us a lot of things when we talk about, fighting for the breath, warmth, and they teach resilience. And over the last couple of decades, the amount of the growth that we saw in this branch in India is phenomenal. Where less than, you know, 32 weeks, 2 decades back, we were having something like more than 50% mortality. And now even from 28 to 32 weeks, pan India, we have something like an 80% survival. So I think while we are talking about the medical advancements and trying to save these babies, along with the understanding of the importance of maternal care to cut down on these preterm issues. What is very important for us to understand is the quality of care that we need to give to all children. And with that, what we need to understand is that there is extremely important for these survivals, these preterms, these babies to have an excellent follow-up, because it is them that they need a special multidisciplinary team. It is not only about the hearing and ROP, it is how important it is becoming to see and monitor them developmentally, and the other challenges that they have with them. So with that, I think it is a pleasure to see that the topics chosen today are not the routine care that they talk about, the preterm. And it was very intriguing to say that they're talking about the follow-up and the development, because that's what we need to give them quality of life. And I would congratulate the Bahrain and the IAP team for this efforts to come towards each other, because universally all of us have a common goal to see that every child gets the best quality of care wherever they are. Thank you so much for having me today as the chair.
Thank you, Dr. Neelam. As always, very nice words of encouragement. So
Yeah.
can I have
Thank
Dr.
you,
Yogesh also to...
Dr. Neelam Mohan, Madam.
Yes, Dr. Yogesh, would you please deliver some
Hello.
of your Dr.
Yeah.
Yogesh, please. Can we have you over here, please?
Madam, your voice is breaking. Hello. Yeah. So,
Yeah.
good afternoon, everyone from here, India. I welcome all of you.
Thank you, Dr. Yogesh. Dr. Ranjan Pejawar.
Hello. Can you hear me?
Yes, Doctor. Dr. Ranjan Pejawar is the man behind the whole event. Can you please deliver some words of your encouragement before we get started with this evening?
Yes. First of all, I thank Dr. Neelam Mohan. In spite of her busy schedule, she makes it a point, as far as possible, to come and join the webinar at some stage and share her wisdom about the various topics. Now, yes, we have about more than 3 million preterm babies every year. We know that whatever we try, the incidence of preterm rarely comes down, mainly because we don't know uh, the pathophysiology of the cause, who will have problems with development. So what we could do is make sure that we follow these babies up, detect any abnormality at a very early stage, and try and reduce the morbidity and make sure that it doesn't impair development to an extent where the baby cannot thrive to its innate potential. So that is what happens when you detect developmental delay early and use early interventions and many other therapies. Dr. Naveen Jain is very apt about these things. He, along with this mentor, Professor M.K.C. Nair, have done a lot in this field. You know, Trivandrum scale, you may have heard, that is one of the early innovations of this pair. And, you know, they have done a lot. So, and we have Dr. Jamila, who is also very experienced in this, as I heard from Vanita, Dr. Vanita. And I don't understand in between this interesting uh, webinar. I congratulate everybody who are uh, who are the contributors of organizing this and participants. The number seen every week is every month is very encouraging, and you know, I'm sure it will be even more popular in the days to come. Thank you.
Thank you,
Dr.
Dr.
Yogesh is there, or Dr. Yogesh is there, or
I
he's
think there were some issues with
Yeah,
his.
Dr. Yogesh, he had some issues with this thing,
Yeah,
but
yeah,
I
yeah.
must appreciate him. I already did initially, but now the official webinar is on, recording is on. He's another person who somehow makes time. You know, being a secretary of an organization is not a joke. He has a lot of things to look after, monitor, and he attending is a very good sign and very encouraging. Thank you.
So thank you, Ranjan Pejawar sir, for your encouraging word and introduction. Thank you very much. Please go ahead. Let us start the academic program because more than 250 people have joined to enjoy our academic feast. Let us deliver it, and the best to the experts, our Dr. Naveen Jain sir and Dr. This our madam will deliver the best for this development topic of the newborn. So Dr. Munna Ali, we met her in the Bahrain and she will deliver best along with the Dr. Naveen. Thank you, sir.
Thank you all, our friendly IAP dignitary. There we come to the point of getting started with our actual CME event. As already been told by all the previous IAP dignitaries, the topic zeroing on today would be a very interesting topic. Early infant development is the theme. Everybody is aware, they did give us an overview of the magnitude of the problem and the scientific activities and the research in the arena which requires us to be aware of the tools available for the practice community to monitor this and to be able to intervene, because it has a definite impact on the future of this development of this infant who needs it. So who better than people who are active in research in these topics, as Dr. Ranjan was telling about their work towards this, like Dr. Naveen Jain and Dr. Mona. We would hear from them and take it as our daily practice guidelines. So we have Dr. Jamila, consultant neonatology from King Hamad American Mission Hospital, who would be moderating along with me. I'm Dr. Manita, IAP president. So this would be the agenda for the day. Dr. Jamila, please take over to introduce the speakers and get started with the CME. Thank you. Thank you all. Dr. Jamila, please, the floor is yours.
Good morning, everyone, and welcome you all to this AMH IAP webinar series. First, I would like to thank Dr. Vanita and Dr. Salman for conducting this webinar series and giving an opportunity to moderate the session. Today, I am privileged and pleased to introduce the first speaker of the session, Dr. Naveen Jain. He is my teacher and mentor and a legend of neonatology. Dr. Naveen Jain, he is a senior consultant neonatologist, has done his TM neonatology from PGH Chandigarh, India. And currently, he is the chief coordinator and head of the Department of Neonatology in the Kerala Institute of Medical Sciences and Health, Trivandrum. So to list the achievements, the publications, the extent of research activities in neonatology are huge. So to be in short, he is the governing member of the Central NNF National Neonatology Forum of India and the executive board member of Neonatology chapter of IAP and the associate board member of the Journal of Neonatology. To add on, Dr. Naveen Sir, he is the distinguished national board teacher and an examiner for the DM and DNP neonatologists and fellowship neonatal programs. And he has been the primary guide for more than 50 neonatal research projects of national board and fellowship programs. And he has publications in more than 26 index journals, and he is a peer reviewer in more than 100 index journals. And he has been the editor of Clohati of Manual of Neonatal Care, Illingworth Normal and Abnormal Development of New Infant and the High-Risk Newborn Infant. In addition, Dr. Naveen has contributed more than 20 chapters in the textbooks of neonatology. Thank you, sir, for joining with us today. And as we know, for all babies, and included the at-risk babies for neural developmental disability, a periodical assessment of their neurological status is important for early detection of developmental delay. As these young brains, they go through a lot of challenges in their neonatal period. Also, it is important for us to know how effective are the early stimulation and interventions are, which have the ability to change and modify these young brains in response to the input from the outside we term as neuroplasticity. So with this short introduction, I welcome Dr. Naveen sir for the first session. Over to you, sir.
Thank you, Jamila. Good to see you. Jamila has been one of the first few persons who trained with us in our training program in neonatology, and herself has trained with great institution Vellore before she joined us. She has done a lot of important clinical research work while she was with us. We'll connect with Jamila after the session once again, and with the permission of the office, we'll get going with the program for the day. So just let me share my presentation. Just a minute. Yeah. Yeah, are you able to see my presentation?
No, no,
No.
no,
Not yet?
not yet.
Yes.
Okay, let me see
I
some
can't
technical
see
issue.
it. I can't see it.
So, no, Naveen sir, it was presentation is on.
Okay, I'll get back to it again.
Yeah.
Is it okay now?
Uh,
Not
Give
yet.
it some time.
we-
Don't interrupt.
yeah,
There you are.
it's okay, sir.
Okay,
Yeah, it's showing now.
It's okay. Now the
thank
slides
you.
visible.
Yeah, thank you so much, and we will have a 20 minutes
But
discussion on what.
sir, we are some rectangular black is. Now it is okay.
Yeah,
Okay, okay.
is it good now? Clear?
Yeah, good, sir. Go
Right,
ahead.
Thank
sir.
you. Thank you so much. Um, Thank you everybody who is in the meeting today, because we always believe that the time we share away from our clinical work and family time for learning and relearning should translate to benefit to our patients and to ourselves as well. In the next 20 minutes, we will look at some clinical pointers that can help us find out very early, like Dr. Ranjan said, detect developmental delays in the high-risk babies, or sometimes even in babies who had no identifiable risk factors. If you look at WHO's new definition of what is thriving, it includes not just gaining weight like we used to talk in older days. It is that the children should be able to play and work normally like any other child. In the next 20 minutes, I will try and drive home Dr. MKC Sir's development observation card message that we assess development at 2, 4, 8, and 12 months. I'll keep repeating this mantra till the end of the session so that we'll all start practicing this at the end of this. When we say play and work in a neonate or young infant, it is these 4 things that the child should do. He should be able to feed, or she should be able to feed without difficulty, have a normal sleep pattern, should be able to play and not cry all the time. Baby should enjoy his infancy and should not be faced with life-threatening events in the process of caregiving. So this is also known as activities of daily living or function assessment. So the first message for my colleagues who are in the meeting today, that development notes of any resident or consultant evaluating an infant of any age should start with these 3. If I write notes on an ICU graduate who was a 24-weeker and follow-up, a birth asphyxia, newborn hypoglycemia, severe jaundice with exchange transfusion, at any age they come back to my outpatient service, these are the first 3 messages I will write. I'll ask the mother, can the baby feed like he should for that age? Does the child play? And are there any challenges in the child sleeping? Because development for the family, for the child is this and not a Bailey scale score. Development has been considered by many people as a very difficult subject, something only developmental specialists can do or a neurologist can do. But if you remember, the difference between adult and pediatric specialty is about evaluating growth and development. And therefore, this should be something that I and you can do every day without having any special tools in hand. Even if special scales are required for research purposes, for clinical use, it is only 2, 4, 8, and 12. At 2 months, a baby should have a social smile. At 4 months, baby should have head control. At 8 months, the child should be able to sit. And at 12 months, the child should be able to stand. Now we'll go through this in a little bit more detail. And if you are looking after a preterm baby, please remember to correct for the prematurity period. That means if the baby is born at 32 weeks, it's only 2 months after when the baby is 40 weeks that the clock or calendar clocks at 0. So social smile would be 2 months after that age. And before you make these evaluations, you need to see whether sensory inputs, vision and hearing can be perceived by the child. Social smile is a very, very important and critical milestone, and there is no bargaining on it. When the child comes for the first 6 to 8 weeks vaccination visit, you must ask the mother, does the baby look at you intently, connect with you, and smile, not in the dreams, but when you start talking to the baby? And if her answer is no, even if she is a nervous mother who wants to see negative in everything, or even if it is a different baby, you do not take this for as maybe we will see it gets better. You immediately note down on the vaccination card that the baby did not register social smile. I need to see the baby again in 2 weeks. Once you do that, sometimes in India at least, parents would change the doctor if they raise doubts about development and get a second opinion. So when they go to another doctor, he should be alerted by your vaccination card, which they have to show that this baby did not do his social smile. You can see in this picture, this was taken during the COVID times. You can see that connect between the baby and the mother, eye to eye, and this should happen by 6 to 8 weeks. And a good social smile should be seen, absence of which is always a serious concern. It could be the first pointer for a global developmental delay, hypothyroidism, or a visual problem. So if there is no social smile, check if thyroid function was done. Was it normal? It may not be too much to even repeat the test. Look for a clouding cornea. You may get a formal visual assessment for refraction. It can be present even in a 2-month-old that the refraction is very severe. Check head circumference and plot it along with the previous values available to see a trend of head circumference. You may even want to look for a cataract. You would also need to do a neurological examination of this baby. And in the next 4 or 5 slides, I'm going to bring out that neurological examination is not by a Hammersmith tool or by a Amyl Tyson or a very special thing. Neurology is about looking at the spontaneous response of a brain and elicited responses. You're standing on the road, you're making some actions, people can judge what you are. And elicited responses also will tell you. That is all about neurological examination. So an infant less than 3 months old, you place the baby in ventral suspension like this. And green color is when the baby's back is straight, head is lifted up, and the limbs are moving spontaneously. If the baby's back is rounded, head is drooping, and the limbs are not moving, they're just dangling, this is not good. So this is one among the neurological examination tools which has very high inter-observer reliability. I and Jamila and Vanita madam would do it just the same way, and has very high predictive utility. That means a good one will lead to a good baby, and a bad one indicates trouble. Similarly, you can have the baby sitting with your arms, with your hands around the baby's chest, and try to see if the baby tends to lift the head from a dropped position. The baby may raise the head completely to midline or may make no attempt to raise the head at all, and that is not good. So you can see in the video next. So this baby is only a few days old, had come for a surgery, and you can see that a few-day-old baby also can lift the head completely when held up like this. So ventral suspension showing that the back is straight, head is lifted, and lifting of head like this are very helpful. You must also attempt to see whether baby has a head lag. When you hold by the shoulders and try to lift the baby from the bed, most babies would lift the head, even a newly born baby, term born baby, would try to lift the head at least transiently, along with the line of the back, along the same plane, and then only drop the head. A baby who makes no effort to lift the head and has a head lag like this is a cause of concern. Now, this leads to a very important pattern of understanding especially in asphyxiated babies who are born at term and needed resuscitation, had seizures, maybe cooled and was in the ICU, that you can look for differential patterns of head flexion and extension. When you make the baby sit like this and drop the head forward, then the extensors have to work. So if the extensors are able to lift the head up, but when you put the baby's head backward like this, falling backward, then the flexors have to pull the head forward. A baby who has good extensor but poor flexor response, objectively, if it is separated by one column on the Hammersmith sheet, then this baby is likely to develop cerebral palsy. So this differential tone is very helpful. Now, expanding further on what we learned till now, that a 6 to 8 weeks assessment or a 2 months assessment, a baby should have a good feeding pattern, spaced by 2.5 to 3 hours, should sleep well, at least for 4 to 5 hours continuously at some point of the day, and should play adequately with the baby by now. He should have a good intent social smile. There should be no head lag. And head circumference should be measured and plotted. This is a 2 months assessment. If you do this, you're very unlikely to miss developmental problems. Remember this mnemonic of development called as a PCR of development, where P refers to persistence of signs, C is for combinations of sign, and R is for resetting. In the same baby who had no social smile, reassess after 2 weeks. If the milestone is still not achieved, this will be called a persistent sign. If this baby had a small head circumference in addition, or a poor ventral suspension, or a head lag, this would become a combination sign. So there are two problems now, a poor social smile and poor ventral suspension. These together exponentially increase the risk of developmental problems. And if they're in a baby who had a risk problem like HIE or prematurity, these three together indicate that you must take specialist opinion and refer the baby for further treatment. So if a baby had severe asphyxia and then follow-up is saying poor head growth, severe head lag, delayed social smile, this is combination signs, and they persist, this baby is in trouble. Whereas the same baby with severe asphyxia, when you follow up, if the head growth is good and no head lag is there, then this baby is going to do well. Now you must be wondering that this is something you already knew. Exactly. We all are doing this subconsciously in our practice every day, but we wish to make this objective so that we do not miss on a given day. So we go to the next milestone, that is 4 months milestone for head control. By 4 months, a baby should have head in midline when held like this in the mother's lap. The head should not drop sideways like in this picture and should not fall forward or backward like in this picture. You can see this video. I'll just show you. See this baby with head control, hardly any wobble, very keenly looking at the toy that is shown to the baby, a small colored paper. Whereas the baby on the right side of my screen is having his head to one side. So a baby, when you see with head lag like this at 4 months and a relatively rounded back is in trouble. The other objective pointer to pick up cerebral palsy early is looking at quantity and quality of movements. And for cognitive development is to look at alertness, interest in the surroundings. Dr. Professor Illingworth, who is a world authority on development, clearly states that it is not the milestone that the baby achieves, but the insurance factors that define whether the baby will do well or not. And an alert, keen, looking around child is much more better than one who has just passed the milestones in a development room. Now, looking at quantity and quality of movements, these were twins that were there with us. One of them developed RSV pneumonia and got ventilated on high frequency for 1 month more. And you can see the difference in development of these two babies at the corrected age of 4 months. See the baby on right, who was the baby who was less sick. Look at his quantity of movements. And the baby on the left is having very low quantity of movements. The variety of movements the baby on right is making, hands, legs, his eyes, looking around, keenly looking at even the curtain that's around you, is so totally different. And this is what is used in general movement assessment to be able to qualify babies. So the Hammersmith tool has picked up this good quality of general movement assessment, that is quantity and quality of movements. In fact, cerebral palsy is qualified by lack of variability of movements in these babies. By 4 months, babies would generally try to roll over. That is because their ATNR would disappear and Moro's reflex should disappear clearly by this age. In fact, an 18-year goes away by almost 1.5 to 2 months of age. And therefore, when you ask a parent, is your baby rolling over? And if they say, no, then immediately you do these two reflexes. Take the baby and lay him on a bed and just push the head to one side. If his hand extends out to that side, this baby cannot roll over. He's trying to protect himself by the ATNR response. This makes this not rolling over clearly a neurological problem. This ATNR pushing out of the hand like this to the side should have gone by 1.5 to 2 months actually. Similarly, we keep doing Moros in the newborn period, but I think it is of no relevance at that age. If a mother says that the baby is not rolling over, he has no head control by 4 months, then you do a Moro's response which should have gone away by that age. A Moro would disappear by 1.5 to 2 months, but a persistent Moro or ATNR at 4 months clearly indicates that the involuntary responses have not gone away. To sum up what we do at 4 months, in India it would be 14 to 16 weeks vaccination visit. The baby should also start catching everything. He should catch an object by its sound. Parents ask the child is not looking to the sound, but it's only by around 3.5 to 4 months that the baby can fully turn his head to see where is the sound coming from. He should catch with eyes. He should track the object very well like this. And he should catch an object placed in the hand, not reach out, but a place that is placed, an object placed in the hand. He should catch it with very good hand use. So this is the catching month, the 4 month. You catch with eyes, catch with ears, and catch with the object placed in the hand. In fact, I can't forget a baby who had a skeletal dysplasia with no hands. And when I showed a toy to him, he was almost willing to catch the toy with his hand, eyes like this, peering and closely getting to the object. So you can see this 4-month-old baby, how he is very keenly looking at things that are being shown to him. He's catching the objects. His back is straight. His head is in control. You can see how he's tracking that torchlight, which I have not even turned on, how he's trying to look at it. And this baby also is very keenly looking at the red ball. So it's catching with eyes and sound. Baby should have their hands open most of the time by 4 months. And it's a very important pointer to brain development. A fisted hand like this is a bad finding. So high risk of cerebral palsy can be labeled by 5 months of age. You don't have to wait till an year. A baby who has no head control, refuses to roll, and then you check for persistent ATNR Moro and they're there. Hand use is poor. Baby has a small head and hypertonia or hyperreflexia. In the next 2 slides, I will show what is hypertonia and hyperreflexia. You try to remember that any angle that you test in a baby around 3 to 6 months of age should be less than 60 degrees. Even though there are several angles defined in a Mile Tyson, this is a single number that will help you to practice well. At no point of time, the angle should be 60 degree or less. If it is so, there is hypertonia. You can see this baby, the adductor angle is less than 60 degrees. And in the next one, it's even more worse, showing already a crossing reflex or a systemic reflex. In the hand, if you do dupatta sign or what is called as a scarf sign, when you hold the wrist like this and try to throw over the shoulder, then the elbow position is what you need to check. A good position is when the elbow is within the body line. And if the elbow cannot enter the body line, it is not entering the body line here, then there is upper limb hypertonia. When it comes to hyperreflexia, this I learned from a teacher, Dr. Mohammed Punju, pediatric neurologist. It is not how much your knee jumps after you elicit a knee jerk. It is the area of elicitation that is important. So if I can elicit a knee jerk from the ankle, it is very bad. A knee jerk which is elicited from the knee may not have an importance unless you see a very good crossed adductor response. That is, you do knee jerk on the left knee and the right knee adducts close by. So this is called as mass reflex or spreading reflex, and it's an abnormal jerk. So by 4 months, Baby should have good head control. Head should be straight. It should not fall forwards. It should not fall to the side. Baby should roll over. If he does
Okay.
not roll over, he should have no ATNR, no moros. It is bad. This is the month of catching objects with sound, eyes, and object catching. The baby should be keen and alert. He should look at whatever he is seeing and catch objects with his hands and eyes. So recapping what our development in the outpatient service would be, at 2 months, the child should be, my first notes would be always the baby feeds correctly. So he's gaining weight, he's sleeping well, the mother is happy, and he plays with the baby. He has social smile, and he lifts the head in ventral position and has no head lag in pull to sit. At 4 months, the baby again feeds well, sleeps well, and plays with the mother. He can track an object both visually and with sound. He can hold an object placed in the hand. He has good head control, rolls over, and has no ATNR, no Moro's reflex. Quantity and quality of movements are good. The baby is very keen. Head circumference is measured.
Oh.
If your OE was not passed, then you would do a Bera test by this age. Now we'll go with the speed a little faster since we are now on the same page. At 8 months, the child should sit straight with a straight back. He should be actually so comfortable that he can pivot around in sitting position. He can use his hands and play in sitting position. If he's tending to fall, it is not okay. If we all are made to sit flat on the floor and extend our legs, we would all have cerebral palsy, would fall backwards, or we would fold our knees inwards. So a baby who can't sit straight with his legs extended out like in the green side, he tends to fold his legs or tends to fall backwards, is having hypertonia. Now you can see this baby who is sitting with a rounded back, head is tending to fall, and his hands are required to support. He is not taking his hand to play with the toy immediately. In contrast, you see the other baby of the same gestation. He's sitting straight, back is straight, head is in control. He doesn't seem to be tending to fall. He's able to play with the pen in his hand very well. So this is the quality of head sitting at 8 months you should be able to see. And hand-eye control should be good by 8 to 9 months. The child should be able to pick up an object. This is a good test for vision as well as for hand. And it is not just the milestone, it is how he approaches the object. Here you can see a splayed approach for the toy, and this is indicating that the baby has a problem. If not doing well, you must check for refraction at this age. And you can see this baby who at 11 months of corrected age is already having a specs. And with the specs, actually, that baby can track an object very well. But if the specs is removed, immediately the baby cannot track the torch. You see how he's tracking the torch so easily with the specs on. But when the specs are gone, this child will not be able to track his object. So this is indicating that if you have a baby at 9 to 10 months of age with problems in reaching objects, please check refraction also. One more thing you should start testing by this age is social communication and development. You offer a toy to the baby, and if he is not interested, if he is not connecting with you or with the mother, if it doesn't take the toy from you, give it to the mother, he should immediately take it from the mother. This is the best size for social and communication development, in the absence of which you will start thinking of autism spectrum disorders. So by 8 months of age, a child should sit straight, pivot, and play well. He should have reciprocal play. He should play with the family and he should be able to do that. Otherwise, he should worry about autism. And the last sign for the day is standing well. Sometimes we find babies not standing by 12 months of age, but you can see what a good quality of standing is. See here. Even if this child cannot stand independently, if he can push a chair like this, you ask the parents, then this child is having no cerebral palsy, no motor issues, no hip issues. Whereas look at the child on this side, this child is tending to fall backwards even if he's holding the chair and completely dependent on this chair for his support. You can see the toe standing and this child is very unstable. She is in for a risk of cerebral palsy. So by 12 months of age, a child should either stand independently or be able to push a chair around easily like this. Not standing at 12 months, we sometimes see in India familiarly large head children with small bodies, but they would have no difficulty in pushing a chair around. Could be pointed to cerebral palsy, spine problem, or hip problem. So if the baby cannot stand at 12 months, look for these. The child should say at least one word which is meaningful by this age. And if not, not responding to name call, you look for familial risk. That is there a child who speaks late in the family, hearing problems, intellectual disability, or social communication disorders in autism spectrum disorders? So by 12 months, a child should be able to stand, say at least one word, and connect and play and respond to name call. I'm getting to the end of my presentation, and I think this is something, a card which you may like to have in your outpatient service. This is what you're doing every day. It's not that we are not doing it, but sometimes when we get busy and we see the same kind of children every day, we may not remember to ask all these questions. At 2 months, social smile, the child lifts the head, no head lag. At 4 months, he has head control, he can roll over, and he catches visually with hearing and with hands. By 6 months, he babbles what is called as half ear, half word, and he can reach out and grasp a toy. At 8 months, the child is intelligent to understand that this is a stranger and can sit, and without support, he can pivot around and play. 9 to 10 months, the child has joint attention. If you show a toy and light and say light, he can look at it. You both are looking at the light. This is called joint attention. Can say mama and tata and has a good quality pincer grasp. At 12 months, 1 year, the child says one word and has response to name call. He can stand with support or at least push around a chair very well. So I really appeal to all my friends who have attended the meeting today that I am not teaching you something new. This is something you all knew, you're doing every day. The only difference is it is a little systematic. Development assessment has to be simple. And remember that persistent signs, if you follow up after 2 weeks and the milestone is not improving, combined signs, two domains are having problem in the setting of a risk factor like prematurity, asphyxia, hypoglycemia, seizures. Together, when you use this simple tool, you reach more powerful prediction, early need to referral and not follow up. We use a follow book called as blue book, but even if you're not having, at least give a notebook to a baby with a risk factor. So when they come back to your busy outpatient service, when you see this baby with a notebook, you say, oh, you had a risk factor. And you have written on the first page what was the risk factors in the ICU. The parents are very happy. You do not miss anything. And if the baby is safe, legally and medically, you are also safe. So the message for the day is 2, 4, 8, and 12. 2 months social smile, 4 months head control, 8 months sitting without support, 12 months standing without support. Ensure that vision and hearing are good. So please remember, we need to help every child that we see to play and work. The child should eat normally, sleep normally, and play normally. And how I ensure this is by giving a notebook. And it is my duty as a pediatrician to ensure that growth and development are normal. So I thank you for giving me this time for being able to share what we do at our workplace. And after Dr. Mona's presentation, I will be available for any questions that might be.
Thank you, Dr. Naveen. Dr. Jamila, could you sign off Dr. Naveen's conversations? Let me get started with Dr. Mona in the meanwhile. Dr. Jamila?
So thank you, sir. Thank you, sir, for enlightening us very clearly and systematically how to demonstrate and when to suspect and a child that they need early interventions to catch up his or her milestones. Thank you very much, sir. We are always happy to learn from you a lot. So,
Thank you. Thank you, Dr. Naveen and Dr. Jamila. We'll have a discussion after the next talk. Dr. Muna would be the next speaker. As I said, our theme is early infant development, and we always try to have speakers from Bahrain also to fill in the same interactive session. So we have another eminent neonatologist from Bahrain, Dr. Muna Ali Abdullah Al Jafari. She has delivered several such CMEs in our platforms. Two of them in our pediatric symposiums also. So let me introduce Dr. Muna Ali. She is She has served as a consultant neonatologist in our national hospital, Salmania Medical College, for several years. As of now, she is a senior neonatology pediatric consultant in Al Rasaliya Medical Center. She has several publications to her credit. Most research of her field of interest are breastfeeding and preterm development, and we were lucky to have her delivering a talk on a topic of preterm development in the past also. Dr. Muna, we invite you and to get started with your topic of CME, effect of neuroplasticity in preterm development. Dr. Muna, can you please join us?
Yeah. Hi, how are you, everybody? I am so happy to be with you, and thanks for giving me this opportunity. Let me do the slide share. Oh, there is the slide, but I want to be slideshow.
Yeah, can you please go to the bottom? You can see it. Yeah, there. Yeah.
Yeah, but I'm not seeing the slideshow.
Yeah, bottom, the third one.
No, I'm seeing only mine.
It's there, the slideshow. But amongst the three, yes, there, that one, the third one.
No.
Go to 100% there, if you can move that.
Let me see. Just a minute. I'm trying to find it. Let me.
You can go up to the slideshow, and then from slideshow you can select.
مش شايفة إن slideshow محمد.
Up in the main line. Yeah. Now this one, yes, yeah.
From beginning here,
Yeah.
Okay.
Yeah.
Sorry for this delay. Just actually, this is my interest field for the development, because as a neonatology, you know, after you take care of acute things, you want to make sure what is the end of that acute after passing the acute stage. So when when I was working as a neonatologist in Salmania, we have what we call the neurodevelopment follow-up, and we were following our patients up to the school entrance, especially the extreme preterm. And this gives us a lot of experience, alhamdulillah, and it helps us a lot. So just I want to share with you this topic, the neuroplasticity and the brain and preterm development, and how it is the early intervention it is very important. And the reason for that, because some moms, when we told them that they have problems in the beginning before discharge, they will be very upset. Some they will not be that much keen. So if we are as healthcare providers, we know what is a neuroplasticity and how it can change the life of that child if he get a proper environment. We do a great job. So the objective of my talk is to understand the impact of a preterm birth on brain development. We explore the role of neuroplasticity in recovery and to see the effectiveness of early intervention strategies. As we know, there is more than 13 million babies born all over the world. This is from WHO, born before 37 completed weeks. And across the countries, the rate of preterm birth is between 4 to 6% of babies born in 2020. And the preterm birth complications are the leading cause of death among children under 5 years, responsible for 900,000 deaths in 2019. So it is a huge number. This is, if we go through, you see where is the, it's the same as I say it as numbers, but this is show where is the maximum number. This is when you see the dark purple is the one which is, they have 15 to 20% the birth preterm rate, and you have the light purple is the one which you have the less than 5%. For us in Bahrain, we have it around 10 to 14%. And this is the same as if it is from in a number. So that's it. And if we see what is the leading cause of death, and in the all over the world, if we see the list, the leading cause of death, if you see here, from 1990 to 2019, neonatal disorders are the one is the causing the disabilities and also the death. So it's not just, we are talking most of the time when we are talking about preterm, sometimes we talk about pulmonary, we are talking about GI, but the one which is really crippling and cause a lot of stress on parents is the neurodevelopment delay, and there will be a lot of disorders, and you will see it is started from just early development. We see just mild developmental delay, or you might have mental retardation. It might affect just the motor function, or the language, or visual spatial function, memory, attention, and executive function, academic performance, behavior. So if you see a lot of neurological defects, and it is according to what type of injury happened, it will be. And in the past, I remember when we were as resident, they are telling us a grade 1, it is okay, it will not cause that much problem, and we are reassuring the parents. But with time, they found even in grade 1, there is a small number, they might have some learning difficulties. So if you see the impairment is increasing as the gestational age is decreasing. If you see that when we have gestational age of 22, it's around 61%. And when we have 28 to 31 gestational age, it's around less than 5, it's around 5.8%. So as the gestational age is decreased, the more is the disability. That's why it's not a matter when you check in your unit, it's not just enough to check the survival. It's also very important to check about the neurological impairment and about the behavioral disorder. The most insult that happen and affect is we have what we call, which is can be started before birth, but because today we are just talking about preterm birth, so we'll see the bulk of injury that happened in the brain, it occurred in the first 10 days. It doesn't mean later on will not happen, but the majority it happened in the first 10 days, and sometimes we are saying in the first 1 week. So where there'll be the acute problems. And the most serious one, which is the brain injury, which is in form of intraventricular hemorrhage. And we know we have intraventricular hemorrhage, we have certain, we are grading it, but nowadays we prefer description rather than a grading. We have it from grade 1 to grade 4, which is involved with just the germinal matrix, or it is intraventricular, or the ventricle dilated and there is bleeding, or when there is the grade 4, which is there is any bleeding in the cerebral cortex. Then the other one, which is the most definitely the most common, is the white matter injury. And this is the one which most of the time cause the neural development. And this can be seen very clearly, it can be seen either by an ultrasound or by the MRI, but definitely the MRI is is more accurate, because in the ultrasound, if it is non-cystic injury, you will not be able to see. Also, the cerebral hemorrhage. Cerebral hemorrhage in the past was really underestimated, because most of the radiologists, when they come and do the ultrasound, or even some neonatologists, they will only do it at the anterior fontanelle. But nowadays, with the when they start to do at the window of the mastoid, a lot of cases of cerebral hemorrhage have been detected. There are other lesions which happen in the gray matter and the deep nuclear gray matter, or subblatal neurons. So also when we need with the MRI, there might be, this is when we are talking about the brain injury. But the problem is not just a matter of a brain injury, because what we see many times, we are doing the ultrasound series. Usually we do it in the first 1 week, then we do it at 2 weeks, then we do it at 4 weeks, and if there's any abnormality, we'll repeat it and we'll see till it's stabilized. But we found that it's not just a matter of the brain injury, what we have the alteration in the brain development, because what we call this maturity, it happened, and when this happened, it also will lead to alter the development of the patient. That's why you see here, it is the majority, it happened in the first 10 days, but still at any stage there might be, because the alteration happened in the brain development. So at any stage, this patient later on might have some neurological deficit. And this is what I was talking about, this maturation of brain as seen in MRI. This is, if you see here with me, this is the typical term appearance. See how it is, the gyri, see how is the gray matter, and also the how is the differentiation. It is very clearly, but when we, and how there is minimum the cerebral fluid around between covering the gyra. But if you see in the preterm baby who have an insult, there will be an increase the extraaxial cerebral fluid, there will be decrease in the gray matter, the ventricular size is increased, there will be the corpus callosum also is decreased, and also the thalamic and the basal ganglia volume have been decreased, and the myelination itself also decreased. So you see there is a lot of difference. And the reason of that, because there are an areas in the in the brain of the preterm which is very vulnerable, and it easily to be bled. And these are, it can be in the germinal matrix at the basal ganglia, which is the most common. Then we have it in the frontal temporal cortical gray matter, or corpus callosum, or the insignium, or in the cerebellum. Is it why this happened? Why this happened? Because there are a lot of factors that affect the cerebral blood flow, circulation, and like when we have, can be, as we said, can start it antenatally, or at the time of birth, or postnatally. Like antenatally, when there's infection, when there's chronic hypoxia and asphyxia, and this will lead to release of inflammatory cells and the cascade of oxidation, and this will lead to failure of myelination. Or at birth, when there is like preterm birth, and patient was like hypotensive, or he was in respiratory distress, or he had some element of asphyxia, it will lead to the the hypoxia will later on there will be reduced, the antioxidant capacity. Also we know that the blood vessels itself is not well mature, so the cerebral blood flow is not well controlled, and this will lead to preterm injury. And then after that, even postnatal factor, that's when we have mechanical ventilation, like when we have pneumothorax, when we have sepsis, when we have bronchopulmonary dysplasia. All this will lead to potentially brain injury. So now this is when we know now that there is a defect in the brain now happen, and so how can we help this child? So that's what we will talk about, the neuroplasticity. What is the definition of a neuroplasticity? The neuroplasticity is the ability of the neural network in the brain to change through growth and the reorganization and response to extrinsic and intrinsic stimuli. It is very fundamental because it affects learning, memory, and recovery from a brain injury. It demonstrates that the brain is not static, but it is actually dynamic and adaptable. And this is very important, because when we see sometime as a neonatologist, like a grade 3, grade 4 intraventricular hemorrhage, we are all the time feeling very upset. I am not saying that this child will not be, might not, he will have, there is a percentage of handicap, and in grade 4, there is a percentage of even death and severe handicap, but when we do intensive program, we can change this patient life. Why I'm saying that? Because the good thing that the neurons, they have they will have what we call the rerouting, when there is a new connections are made between the active neurons to create an alternative neural pathway. This is before the intervention, and this is after the intervention, and you see how more they found another way, because the myelination is not yet well developed, so the synapses will be increased, and also they will do or what we have a mechanism called sprouting, when a new axon and dendrite extension allow existing neurons to a new connection. Suppose they have a certain pathway, they will change to find an alternative pathway. So it will help for improvement. And this is not just for in children, even in adults, when they have bleeding, when they do extensive physiotherapy, the brain will have the capability, but in children, the improvement is much better. What are the forms of a neuroplasticity? We have structural plasticity, and this involves changing in the physical structure of the brain, where there will be neurogenesis. What does it mean of that? Generation of new neurons, or synaptogenesis, which is, as we said, they will have formation of new synapses. They will connect between each others. And this is changes occurred in gray and white matter, and it affects the volume. We have the functional plasticity, and this is involved change in the brain function without altering in its structure, and it includes the strengthening the synaptic connection, as we said in the diagram, we saw in the diagram, and also reorganization of the neural pathway. And we have also cortical remap. That's mean when a brain region take a new function. There are other terminologies like synaptic plasticity, developmental plasticity, experience-dependent plasticity, or maladaptive plasticity. And the maladaptive plasticity is very important. This is when the neuroplasticity is, we usually, now what I'm talking, we usually talk about positive regeneration, but sometimes there will be negative change and lead to abnormal neural function, and the patient will have small cortical volume, they will have seizure disorder, and even delay. So what is the impact of a brain injury and this maturation in neuroplasticity?
I request the audience to mute themselves, please, because I'm not under control for this.
Can I continue?
Yes, doctor. I don't know if I can.
Okay. We need to, one, as we say, there is negative impact. And now first I will talk about the negative. I will talk about the negative impact. The negative impact is that when there is an altered neural connectivity, and the studies using neuroimaging techniques like MRI have shown that the preterm birth can lead to altered the neural connectivity patterns, and this can affect how different brain regions communicate with each other. And this can result in difficulties with cognitive function like memory, attention, and executive function. And that's what we see. That's why you see some preterm, they might have the attention deficit syndrome, and they might have the working executive function is less mature. They might have reduced neuroplasticity, and research indicate that preterm birth can reduce brain's capacity for neuroplasticity. And a study published in Journal of Neuroscience demonstrate reduced cortical neuroplasticity in adolescent born preterm. And these children had lower level of cortisol, which is important for learning and memory. So this is the negative. So now we will talk about the positive side of the neuroplasticity, which is occurred when we do early intervention. According to Cochrane review in 2012, that early intervention program for preterm infant have positive influence in cognitive and motor outcome during infancy, with the cognitive benefits persisting into preschool. And following development as early as possible allow us to identify concern that taking the advantage of the plasticity. So the early intervention is not started after discharge. The early intervention started even before delivery, but as I told you, we are just now because focusing at the time of delivery and onward, that's why. But before the delivery, when we give the antenatal steroid, when we give the magnesium sulfate to prevent the preterm, we know that magnesium sulfate and antenatal steroid is brain protection. But now the baby is delivered now. So how we can help for early intervention? This is when we create in ICU environment with showing all these guidelines. And you see most of the NICUs, they have this guideline, according to 7 or 8 important points. First, the first important is the minimizing stress and pain. We know once the baby born, what we will do the first thing? We'll do suction, we do intubation, we do booking, and we are thinking, oh, they are preterm, they are not feeling, but no, they are feeling, and the pain and the stress, because will lead the cortisol will be very high and lead to the inflammation process to be all the time active. So please, all the time, do gentle suction, gentle handling when you are intubate. Try to avoid intubation when it's not necessary, because nowadays most of the unit, they are starting in the labor room with the CPAP, and this is less invasive. Then also the other thing is the temperature. Maintaining the baby temperature is very important. From labor room to the unit, it's very important. The other thing is the positioning and handling. When we are positioning, we are all the time keeping we need to change the baby's position. We need to keep them in nest bed so they feel more comfort, change head one side to one side, keep them in a prone position with apnea monitoring. And when you are handling the try to be synchronizing, not any time you just decide to do blood collection or you decide to take the vital signs. All the time synchronize the nurses work with the doctor works, and all the procedures to be together and let the baby to rest. And this is to came with the time about the sleeping. These babies need to take a time of sleep. So to have a sleep, we have to have a quiet in ICU. The sound, we should not exceed, all our instruments should not exceed certain decibels more than 40, because they found by any increasement of 10 decibel and above it affect the more than what is recommended, it affect the development. And the light, we should do we use the dim light, we have to use the quiet hours, the protecting skin by humidity when we are applying in the first 1 week, and later on by applying the some oil protections, like in some countries they are using the almonds, sometimes they are using the sesames. And the most important is the optimizing in nutrition, because if you do all these things and the babies are not thriving well, you will need to you will have impairment. And when I'm talking optimizing nutrition, I'm talking about breast milk and total parenteral nutrition if it is indicated. And with the last but is not the least is all the time keep the parents as partner, not as we are opposing to them. Let them share with us the decision. Give them time to spend with their kids. That's why most of in ICUs in the world, 24-hour is open. Let the mom and the father do the kangaroo care, and a lot of studies showed how the kangaroo care is help in development, in weight gain, and protection. So because what we noticed that some units, because the baby is on ventilator or IV or lines, they will avoid giving the babies to the mom because they are scared of the tubes. So what you need, secure the lines and give the mother the baby and be observer with her. So this also will lead to better rebound with the better bonding between the baby and the mother, and she will be more cheer up. Even psychologically, she will be more stable. And if the condition cannot be allowed, at least let her open the incubator and touch the baby. Let her talk to him, read to him. This is very important. And for us, and also for the parents, the infection control, the hand wash is very important, because after all these things, if the baby get infection, we will lose the patient. So now this is at the level of the NICU. So the neuroplasticity is started from here. It's not started just after discharge, because most of us sometimes we are talking only after discharge. We'll talk about the multidisciplinary, we'll talk about physiotherapy, we'll talk about stimulation. Stimulation should be started from the NICU. That's why most of the units, they have a physiotherapist, the social worker, with the neonatology team, with them when they are doing the round, because they want to start detection very early, especially when we are the physiotherapist. They should come weekly with the round. Why? Because to assess earlier and detect if there is any changes. Early detection and early intervention will lead to better outcome. So now, after discharge from the NICU, I am sure you all of you heard about what we call family-centered care and emotional support. This is the family, they are the one who are the center of care, and we are just supporting them. And this is now with the presence of the IT, we have the digital visits, and this will help to give very emotional support to the parents, regular communication with the mothers, to encourage them to give care, to help them to answer their questions, because especially in the first 1 month after this, after the baby stay like with us around the 3 months, the mother, she will feel she don't know how to deal with the patient. That's why we start preparing the parents when they are in the unit, but still when it comes to reality, they will be very stressful. They need help, they need cheer up. So we need to have what we call the family-centered care. We need to, when the mother take him home, we need to we'll give her a clear, structured discharge plan. We home visit some units, some countries, they have the home visits, which is done by the community nurse and one physician, regular follow-up, and we are reminding them, we send them a note, a message that your baby is having follow-up, and we know these babies having a lot of appointments, so if we didn't remind them, they might forget about. We educate the mother about the kangaroo care, about the breastfeeding. It's not because what we, at least in my experience, what I notice, the mothers will be very keen about the breastfeeding when they are in the unit. Once they are out, they will see them gradually, they are out of breastfeeding and depending on the formula. But we are, as healthcare providers, as pediatricians, we have to promote for breastfeeding, because we know how much it is affecting the health of these babies. And we know with the breastfeeding and kangaroo to reduce the hospital readmission. We make sure about the immunization and the special immunization that they need. We do follow up the development, as my colleague previously he said, about teach you about the development, but make sure when you are doing the development assessment and plotting the growth chart that you are doing the corrected, according to the corrected age, because this is very important, and you go through all the development assessment. So when you detect it early, you will help for improvement. And if we're doing this care, you will see it will reduce the neonatal morbidity and the mortality and even the readmission. Why we are insisting on that? We know because we know that the brain development is the majority of the development is occurred in the first 5 years, and especially in the first year. So if we encourage the parents to be doing intensive stimulation, this will help a lot to go to minimize the disability if it is there, and if it is mild, most of the time we go over it. At birth, if you see here, at birth there will be the peak of the synapses. At the age of 2 to 3 years, this is the time of the language development. At 4 to 6 years, this is the higher cognitive function, and then 7 to 12 years, there'll be the fine tuning of skills. So we need to do with encourage them to have teach them about how they do the brain building activities, like at least what we are doing. We are giving them for the first 3 months the white and the black cards, talking to them, talking to the babies, the massaging. Really, and at least I saw how the massaging is really helping the baby to relax, to sleep well, and also increase the bonding, and it is a good stimulation. So this is very important. And also the kangaroo care, skin to skin, has we not the skin to skin, it is very important to be continued. There's a lot of studies regarding the music, how it is affect the brain, but it's depend, if not for music, for us, like in our religion, we are using the Quran, it helps. The physiotherapy, the occupation therapy, and the social interaction. So we need to have this patient to have safe space for emotional security. We need rich stimuli appropriate for the age, regular sleeping. Sleeping is very important because for memory consolidation, and the nutrition is very important. This is what I was talking to you. You see, what is the peak? It is in the first, the brain develops in the first year. And usually it is most in the first year, second up to the 5 years, then after that from 5 to 7 little, but the majority is occurred in the first between 0 to 5 years. That's why we all the time insist and try every visit when they are coming to us, we'll tell them the importance of the physiotherapy, occupation therapy, and the stimulation. So if there is any message I want to deliver it to you from this short talk, is that third trimester is vital for rapid brain growth, including demyelination, chiral formation, and synaptic organization. Preterm birth interrupt these processes, leading to structural and functional alteration, but early intervention promote positive neuroplasticity, developmental care by implementing developmental care practice in the NICU to minimize stress and promote healthy brain development. Long-term follow-up is very important to monitor the neurodevelopmental outcome and provide ongoing support through the family center care. Thank you.
Thank you, Dr. Muna. That was very interesting overview of neuroplasticity right from perinatal age to how we can implement early development intervention plan. Thank you, both the speakers. We will open the floor for the audience to unmute themselves to ask direct questions for discussion, after which we will have an interactive discussion. Dr. Jamila, if you can lead the questions from the audience in the online chat box, that would also be good. So for now, let's open the discussion for the audience, if there are any.
Hello, hi. I put a couple of questions in the chat box. If Dr. Jamila can have a look at it, please, and forward it to the respective people. Sorry, I'm Dr.
Yes.
Saha. I'm from UK.
I think there are two questions. I couldn't get there. I'm not able to open the chat box. I've got two questions for Dr. Naveen sir. There's one question: for what support do you have in community for early diagnosis and picking up of abnormalities?
ये देखला ना सोई पड़ता पुणी आज अब जहाँ पचास मना कर सी टाइगर लायन देख लो ना
Saji, can you mute everyone and the video also switch off?
Naveen sir.
Dr. Jamila, you can also mute some of the unwanted conversation that's happening. In the meanwhile, Dr. Naveen, Dr. Jamila extrapolated a question from the chat box.
Yes, yes.
Did you get that? Yeah.
Yeah, I got the question. And in our community, the ASHA workers or the community workers had used the Trivandrum development scale, which was mentioned by Dr. Ranjan, to screen more than lakhs of population to pick them up
Saji,
early with
sorry, Dr.
milestone
Naveen.
delays.
Saji, can you please mute all and close the video, please?
And to, refer them to the places where specialist care can be provided. And what they could find that it was possible to use only a single milestone at a particular age to be able to screen community population and make it much more effective. What they also found that contrary to what we keep doing in high risk follow-ups, the larger problems were not cerebral palsy or necessarily global developmental delay. A large amount of problems were language related problems, communication related problems, as well as hyperactivity problems. And these were picked up by simple tools like the Trivandrum Development Scale. So I think the community has a very large role in screening, and sometimes very simple standing cards outside an outpatient clinic can guide parents. I'm aware of the CDC America having a very simple app for the parents where they can enter the age of their child, and a similar one in NICE UK where the parents can match their child's development with a given age and then try and guide them. Recently, the MBFHI model of India has developed a mother and baby child card, which also includes the milestones.
Thank you, Naveen. I just wanted to say, how do you audit your practice? Is there any tool that you use to audit this practice?
I think for community outreach, currently there is no audit to find whether they could pick up all of them or they missed a few. But within our own resources, for the last 24 odd years, we have having a registry of all babies who are discharged from the ICU. Our drop to follow-up rates are or the order of 26 to 27% overall, but all others are recalled periodically to be able to ensure that. And as understandably, the low risk ones are the ones which get lost to follow up, and the ones with higher risk factors tend to come back more frequently.
Yeah, thank you. So just a comment here, because we follow in UK, we follow a system which is a universal. I know it's a different healthcare in UK anyway. So we have a app called the BadgerNet app, which is available to all medical professionals throughout the country. So even if the child moves between areas, they are picked up, because all the episodes of visits and everything is recorded. Everyone records it on one app, so that whoever is taking this app forward, or whoever is, even if the child moves from north to south to east to west, everything is recorded on that, so that the follow-up is much more streamlined and things are picked up very early.
Yes, we really acknowledge the power of the integration of primary care services with referral services in the UK, and we are learning, but very, very far from referring a baby to primary care and to and for. So that is a very weak link in our country, at least.
I think that's where the first things are picked up, isn't it? Because by the time they come to hospital, it's quite late.
Absolutely.
Yeah. And there was, I think I put one more question to Dr. Mona. What are, I think, two parts basically. One is, we didn't speak much about caffeine, because caffeine in newborn less than 30 weeks is now it is a part of an optimization program. It is a neuroprotector.
Yeah, that's true. Yeah, sorry, I forgot it. Yeah.
Yeah, so caffeine is probably is a very, very important thing in any baby less than 34 weeks, basically, for routine. Even if the child doesn't have apnea of prematurity, it should be routinely used for all babies who are less than 34 weeks, basically.
Yeah,
and
I totally
my
agree.
question to your practice, when would you time the MRI? Because you said something about MRIs. Now, a child who has had an asphyxia at birth, his MRI or her MRI is done between 7 to 14 days.
Yeah,
that's fine. But for a preterm baby, for understanding the neuroplasticity or brain development, would you routinely do an MRI, or when would you do MRI? Because the MRI comes with an extra facets of general anesthesia, sedation, all that stuff. So when is the timing?
Yeah, for us, the screening, what we are doing, the screening is the ultrasound. We are doing this serial ultrasound till the time of the discharge, till the time up to reaching term, okay? But if we have a patient like showing, like in the ultrasound, showing the BVL, periventricular leukomalacia, or when we have grade 3 or grade 4 intraventricular hemorrhage. These are usually will do it. Usually will do it around after the patient will do it around 4 to 6 weeks, or when they reach according, the appointments are late, but we do it before discharge, and we make sure this baby will have MRI before going home, because we don't want to mess, and we want to see what is the plan. So that we do for them before discharge, definitely.
Yeah, but for preterm babies, the myelination may not be complete, because if you look at the papers and research, the research says delay MRI as much as possible.
We do it, we make sure, but because what we do it, we try to keep it near between 36, 37, but sometimes, yeah, because rarely, especially the extreme preemie, rarely we discharge them before they reach 36, 37 weeks.
So babies who may have a normal ultrasound scan can, because a lot of these babies can have problems later, isn't it? My question was slightly different. Babies who have got problems in the ultrasound scans, UMR, that's a different issue altogether. But babies, preterm babies who have a normal ultrasound scan, would you normally, is there any indication for doing MRI down the line, say 11 months, 12 months? Is it a routine that you practice, or is it something that based on symptoms?
No, we are not doing it routinely. What we are depending on the follow-up and the neurodevelopment assessment, because also for us, we are as a neonatologist, we are doing the assessment, but also we are referring these babies to, we have the neurodevelopmental consultant to do the official assessment. So anytime we feel that there is a sign of even mild sign, we will do it. But I will tell you the truth, because the process, and sometimes we prefer to do it before discharge rather than after, because small in our hospital, when we want to do an MRI for a patient who is less than 6 months, sometimes they want GA intubation. So most of the time we might delay it till they reach a good size that they will not need will not need sedation. But because we are believing, at least for me, I believe that, okay, we do MRI, it will help us to detect, but we are doing the early intervention, we are doing the physiotherapy, regular physiotherapy, we are teaching the moms, we are sending them the videos, and they are on regular physiotherapy and assessment by the physiotherapist. So if there is any mild things with the physiotherapy, it will improve, and once they grow up, that's the time we do the MRI, but not all of them, no.
I think so. So the take-home message is delay MRIs as much as possible unless there is specific symptoms, signs, because MRI is probably it's just an investigation. I think monitoring clinically will be the most important factor on facet of neurodevelopmental outcome, because unless there are clear markers that MRI will going to assist you in is it going to change your decision about anything else? Only that's the reason. If it helps you clinically, then only MRI is useful. I think that's the bottom line. I think probably the take-home message for everyone, that MRI is an investigation which has its own issues with GA sedation. So try and assess clinically and keep radiology the last resort unless there is a definite change in management with your radiology plan. I think that's probably something we take home. And caffeine, as I said, probably is a very important medication for babies' neuroprotection as well. Thank you. Thank you. That's all my comments. Thank you.
Thank you for the interesting discussion there. And I'm really sorry about I kind of lost control over the audience unwanted sound in between interruption there. Dr. Jamila, could you want to take over some
Sir,
of
I got in between, I got some interruptions. So there's one question, is some children are able to do activities earlier to their age? So it's discussed earlier, can it be abnormal for Naveen,
No.
sir?
The range of achieving milestones, as they say, is very variable from child to child. And a child who does earlier is neither better nor in trouble. I am sure that possibly what the question was asked may be regarding the rollover milestones. For instance, sometimes parents mistake a accidental fall of a baby from supine position to lateral as a rollover because the baby is very stiff, hypertonic, and tends to just fall over and they think it's a rollover. But early milestones neither indicate a better child or a child with problems. So milestones are only helpful in pointing red flags. That is, if the child is not achieving milestones at a given age, you need to pay closer attention. But it cannot label a child as abnormal. You can only child there is a delay. Deviation from development, which means abnormal, is a combination of assessment neurologically and, if necessary, by other methods.
Thank you, sir. So there's one more question. Is there any early signs that can prompt us that this baby will have delayed milestones during their NICU stay?
Yes, within NICU also, there have been many tools that have attempted to predict much before the child is ready for discharge. Periodic measuring of head circumference can be helpful. Poor weight gain has been used to predict ROP. Multiple morbidities and risk factors in early period have been able to suggest that children will have problems. But as it is understandable, the longer you follow up, the false positives becomes lesser and lesser. So our own study, which was done by our colleague and Jamila's senior, Dr. Radhika study, had looked at risk factors, which included extensive resuscitation at birth, symptomatic hypoglycemia, gestation less than 28 weeks, and neurosonogram being abnormal as a very good predictor for identifying babies with disability. Presence of more than one risk factor increase the chances of having problems. So they can only select populations which need closer follow-up. Those without risk factors also need follow-up.
Can I ask?
Thank you, sir. And one more question. Do you use any assessment tool in the clinical practice for day-to-day practice?
Yes, there are tools which can be used. For example, the Hammersmith tool, Hammersmith neonatal neurological examination, is a very easy to do tool at the time of discharge of all babies. The same infant tool can be followed up later to predict motor developmental problems early. General movements is more accurate but requires training. We use Denver Development Screening Test, which is a lot easier to do than the Bailey scale, but its accuracy is lesser than Bailey scale. But what we propose today is like a milestone check 24812. It's not a formal tool, so it cannot be cited as a research model, but it is extremely useful to pick up functional problems.
Thank you. I do not see any more audience queries. Thank you, Dr. Naveen, for all the answers that you could for the questions posed to you. Can I steer the discussion to a different level? The whole bottom line of early detection is with the philosophy of understanding that early intervention will have an useful impact on outcomes. So, what are the studies available, and can the detection be earlier? Because many discussion centered over certain red flag milestone points like 2, 4, 8, 12, as you said. Can it be involvement of parents in assessing any anticipatory guidance to parents to keep, because most of the outcomes focus on the whole stress on the whole family, not just the physical outcomes of the children themselves. So, what are the studies that encourage early intervention plans, which give us a overview of results of early detection being helpful for the outcomes? Are the research supporting that our economics and investment on early intervention has paved way in the last few decades? Can you give us an overview of this, Doctor?
I'm not sure this was to Dr. Mona or to me.
Both of you, because both of you happen to talk
Want me
about this.
to talk about
Because
it? Okay, first, the early detection, as I said, if you have a physiotherapist with you in the round, or during at least once a week she came, she assess, and she not assess our sick patients. So I'm talking about the babies who are now, they are 32 weeks and over, they are now out of the acute stage, acute stage, till they are just for weight gain. If she come and assess, you will see her, she will tell you, oh, the right side is more hypertonic compared to the side. Please change the positioning. Please put the nest like this. And many times about the torticollis, we see very common, because the incubator is very restrictive field, yeah, incubator. So when we shift them later on to the bassinet, you will see the difference. So so the early assessment by presence of a physiotherapist who is coming to your unit and assessing these babies, it will help. She will teach the nurses, and she will teach the parents. For us, because a lot of load on them, on the physiotherapy, what they do before going home, they teach the mom all, they let her to take a video of that the session. They will tell her what to do, and they will tell her to continue till the next appointment. So the mom is doing it on daily basis. So it's not a matter that we'll go home and we'll go the physiotherapist to do it once a week or twice a week or 3 times. So it's needed to be done daily. And we know these babies what they need, especially in the first few months. If we do the stretching, if we do the massaging, if we do the tummy, we put them on their tummy time, it helps a lot to avoid a lot of undetected. Then later on, when they come to you for assessment, because for us, what we do after discharge, we tell them to come. We have two type of a clinic. One clinic is seen by chief resident, will see him after 2 weeks. But meanwhile, there is these 2 weeks, they can communicate with us, they can ask of anything. And then after that will be seen by the consultant. And when they come, which is within 1 month after discharge, that time he will reassess. And every time we reassess, if there is any sign of showing any sign of problem, then this is the time we communicate with the physiotherapist, and we'll tell them our observation, and then they will do the program accordingly. And it's very important to have a really skillful physiotherapists who are specialized pediatric physiotherapy, not general physiotherapy, because it make a difference. I saw it make a difference. One who is really specialized, they know the technique, and it helps to improve. And I saw those who are really they are having severe hypotonia or spastic, but with early detection, it helped a lot. And then after that, the presence of the multidisciplinary clinic, where it's the ortho, the neuro, the physiotherapist, the dietitian, the social worker also it helped. So all these things together it make a difference.
Thank you, Dr. Munna.
Thanks, Dr. Mona and
Dr.
Dr.
Naveen.
Naveen. Yeah, I think the important is the follow-up and the early detection of even minor signs. And the most important, as Dr. Naveen say, you should reporting this one in the notebook. So any doctor who's looking to seeing the notebook, then he will follow up this patient and to do the detecting the other signs, and then it will be easy to detect any deviation in the development.
Sorry, Dr. Mohammed. Yeah, I was just asking Dr. Naveen. So what are the research available proving that the early intervention is, after all, important and has an impact on the outcomes? And what are the outcomes that we track, not just the developmental outcomes, the impact on the parents and the social outcomes, etc. So Dr. Naveen is active in this field of research. So over the decades, what is the impact of our early intervention that we are all focusing on? How beneficial it has been?
Yes, Dr. Vanita. Some of them very objective ones. For example, picking up refractory issues, hearing problems, thyroid dysfunction, hip problems, and like Dr. Muna referred to, tone abnormalities. These are objectively measurable problems where you can pick, and there is a very clear guideline available as to within how much time you need to intervene, and it is very obvious that intervention will make a difference. But there's yet another not easy to measure effect of early screening and parent involvement in this process. Most often, the parents who take home a baby from an ICU who has been sick in the ICU for a long time, or who has had an antenatal problem which points that developmental problems could be there, they are unable to even do normal parenting. They're bogged down completely, and even simple stimulations that they would do at home as a parent fails completely. So periodically meeting both the baby and the family allows you to have the mother and baby, or the family and baby diet developing, because maturation of development is a two-way process. If the baby is active, the parents become very happy. They further stimulate the baby, and this is returned by the baby to the family, and this doubles up. So if parents are completely demoralized and not involved in early stimulation, they also need to know the importance of why they need to come back. So while they're in the ICU, we take education sessions for them, for having them to understand that when they do refraction assessment at this time, or if they do a periodic check for their social development or child behavior assessment at a later age, how it is going to impact his preschool performance or school performance. If they understand that, you do not need any reminders, they would come back themselves to the follow-up system. They would be able to pick up, like Dr. Bivan said, they would pick up themselves early and report to their primary care facility. So involving the parents in the process in understanding has been measured objectively in research in two ways. One way is direct interventions that have been done, and I think I can list around 10 of them, vision, hearing, thyroid, hips, tone abnormalities, and so on. Specific disorders being picked up as a part of systematic process, but these are only minority. The majority is where if the parent is addressed directly, then stimulation of the child would go a long way. And we know that language and cognitive development is not a innate behavior, it's a learned behavior. An early age is very critical for language and cognitive and behavior development.
Thank you, Doctor. Thank you, Doctor. Thank you both doctors, Dr. Naveen and Dr. Mona, for the answers of the queries raised by us. If there aren't any more questions from the audience or such, we can sign off. To summarize, Dr. Naveen's talk was about early detection, very crisp and apt to the practice community. The minimum of the bare minimum of 2, 4, 8, 12, and the milestones to pick. And once you do your early detection, what next? Neuroplasticity is there for you to, all is not lost. You have early intervention, which can guide you, navigate you to the difficult times that are ahead. And we did have a discussion about what is the crux of the whole discussion today. Early intervention to have a family-centered approach where parents are the center of the whole discussion. And that's essential to give you productive outcomes for the troubled infants. So thank you all. Dr. Mohammed Salman, if you're around, can you please deliver the vote of thanks? Thanks, everybody. Until next month session, goodbye.
Yeah,
Thank
sure.
you.
Thanks.
Thank you.
Thanks
Nice
to our speakers and also to all delegates who stayed till the end. We have almost 400 delegates attending the session, and they continue till the end. I think it is very interactive session today, and see you next month.
Thank you. See you.
Yeah.
Thank you, Bahrain team, for giving us such a lovely audience to listen to.
Thank you,
Thank
Dr.
you, sir.
Naveen. Very
Thank you,
kind of
Naveen,
you.
sir. Thank you.
Naveen, sir.
And thank you, Dr. Vanita, for the wonderful moderating, and Dr. Jamila. And Dr.
Thank you
Viwan for
all.
your input. Yeah.
Thank you, Dr. Yogesh. Thank you, Dr. Munna.
Yeah. And
Goodbye,
more than
Dr. Naveen.
400 people have joined. So it's difficult to manage on this all Zoom platform.
Thank you,
Because we
Naveen.
have to
Well
mute.
done.
Yeah.
Thank you.
Well done,
Thank you, Naveen.
well done,
Thank you for
everybody.
Yeah.
Well done, everybody. Proof of the pudding is in the eating. More than 400 delegates and more than 380 till the end. Great.
Yes, yes, sir. Yes, sir.
Kudos to everybody.
Thank you, Ranjan. See you
Wonderful.
soon. Bye-bye.
Thank you for the interactive audience. Thank you, Dr. Bin.
Bye-bye. Good day.